Thank you for joining us today, sir. Last but not the least, we have the young and dynamic Dr. Santosh Suman, who will be co-moderating the session with me, Dr. Vandana Sundaram, again from Shankara Eye Hospital, Coimbatore. So as discussed earlier, we have 5 presentations. So we'll have the first 2 presentations, which are a little similar. So we'll have the first 2 presentations and then followed by a discussion. So the first one would be post cross-linking progressive ectasia presenting with corneal perforation, presented by Dr. Anita V. Shabina, if you could please play the video.
So
Good evening to one and all. Post CXL progressive.
Anita, just 1 second. I just would like to thank Dr. Gyan Mehdi for doing this season 3, and would like to also thank Paras for initiating it. And again, our gratitude to Shankaraya Foundation for joining with the Cornea Society of India today. So thank you so much. I think we can begin now. Thank you.
Good evening to one and all. Post CXL progressive ectasia presented with acute corneal perforation. An 18-year-old female presented to us 10 years back in 2010 with progressive keratoconus in right eye. Her Kmax in right eye was 57.4, central corneal thickness was 457. Left eye, the Kmax was 49 and the central corneal thickness was 496. She underwent standard epithelial of corneal collagen cross-linking with isotonic 1% riboflavin drops. Her keratoconus was stabilized over a few years, but there was a central area of concentric thinning that was progressing on serial photographs, and her CCT was 291. A few months back in November 2023, she presented to us with a sudden onset of perforation following a trivial injury by her 4-year-old infant. On examination, her right eye revealed a perforation in the center of the ectatic area, and the eye was soft with a flat anterior chamber. Immediately, a cyanoacrylate glue with the bandage contact lens was applied. Postoperatively, the anterior chamber was persistently shallow with the peripheral anterior synechiae. So after 1 month, penetrating keratoplasty was done and postoperative period was uneventful with a formed anterior chamber, and her vision improved to 618. Why there was a progressive thinning in this case? So maybe the hormonal imbalance in the consequent pregnancies, or the preoperative thin CCT value. But in our case, it was 457. Is there any protocol to be followed in post CXL progressive ectasia cases when to intervene? Do we adopt new methods like contact lens associated CXL in thin corneas in such case scenarios? What is the pathophysiology behind post CXL progressive ectasia? Thank you.
Can we move to the second case?
Can we please move on to the second case, cross-linking cornicles by Dr. Neelima Balakrishnan?
Good evening, everyone. Today I shall be presenting a case of sterile corneal melt that occurred 10 years after corneal collagen cross-linking and our experience with similar cases. Our patient is an otherwise healthy 28-year-old male who's an engineer by profession. He came to us as a known case of keratoconus diagnosed from elsewhere and had already undergone corneal collagen cross-linking from a local hospital 10 years ago. Although we did not have the protocol details that was used for the corneal collagen cross-linking, it is to be noted that the patient gave history of collagen cross-linking being done twice in the right eye, first time 14 years back and then again 10 years back. His presenting complaints were history of recent onset diminution of vision, foreign body sensation and watering from the right eye. There was no history of recent trauma. On retrospective questioning, it was revealed that the patient is a habitual eye rubber and history of prone position sleeping was also present. The patient was not on any topical or systemic medications. On examination, the vision was 612 in the right eye, which was not improving further. And in the left eye, it was 6-9 parts, improving to 6-6. The lids and adnexa were within normal limits. Conjunctiva showed circumcorneal congestion. Cornea showed central corneal thinning with stromal melt and decimatocele and surrounding corneal stromal haze. And in the left eye, showed mild anterior stromal haze post corneal collagen cross-linking. The clinical photograph of the right eye shows a well-demarcated area of central corneal thinning with stromal lysis. And in the slit lamp image, here we can see the decimatocele in the right eye. We planned the patient for a deep anterior lamellar keratoplasty for the right eye under general anesthesia. A manual DALC was performed for this patient. These are the postoperative images of the patient after undergoing DALC. The graft was clear on postoperative day 1 and the patient continues to do well at 1 year follow-up with visual acuity of 612 parts improving to 6/9. We had two similar cases that were referred to us with sterile corneal melt occurring more than 5 years after an uneventful corneal collagen cross-linking. We noted that in these cases the presentation was often delayed as the patient was relatively asymptomatic until significant corneal melting had already occurred. These patients were managed with either DALC or penetrating keratoplasty and had good visual outcomes. To conclude, although corneal collagen cross-linking is a safe and effective option in the management of keratoconus, severe complications like sterile stromal lysis are rare but still possible. Published literature is mostly on cases of sterile stromal melt occurring immediately after corneal collagen cross-linking. However, it can occur as a late complication as well, as seen in these cases in which it occurred more than 10 years after undergoing collagen cross-linking. Ongoing chronic keratocite apoptosis has been postulated as the causative factor along with other possible risk factors such as increased UVA exposure, prolonged use of topical NSAIDs, and systemic conditions such as diabetes or autoimmune disorders. And as with everything else as far as keratoconus is concerned, pro-inflammatory cytokines play a major role in this complication as well. Thank you.
So those were the two cases, one by Dr. Anita and the other by Dr. Nilima. So we shall start the discussion, and I would like to request Dr. Anita as well as Dr. Nilima to unmute themselves. So considering the first case was a case where cross-linking was done. However, the patient was documented to have progressive corneal thinning. My question would be to Dr. J.K. Reddy. Sir, do you think you would have intervened a little earlier when you noticed progressive corneal thinning over the course of a few months?
She said the progressive keratoconus, post CXL, Dr. Anita presented as progressive keratoconus with thinning. Actually, these cases, what we saw in the cases Dr. Nilma presented and few more cases which we operated, the keratometry is very good and very flat. There is no steepening except at the descent. Once they develop in the center of the haze melt, it will never heal. You see a melt and a persistent epithelial defect which has not healed within 10 days of conservative management, better to plan for surgery in these cases because the CXL already has killed keratocytes and most of the stroma was altered. So it is not going to repair on itself. It's more or less like a dead cornea sitting in the center of a normal cornea. So it won't repair itself. So we have to plan and go for surgery. But these patients are very reluctant to go for surgery because they are painless, very minimal irritation they have. They are very comfortable and they have reasonably good vision. They are not bad. 618, 612, sometimes 624. Good vision they have. So they are bit reluctant.
Yeah.
Dr. Gaurav, you have any experience? And Dr. Fogla? Fogla also, I think, once when we were discussing, he was saying that he had few cases in something like this.
Yeah, we had two cases. We have had two cases, and frankly, over 15, 16 years of doing CXL, we saw these two cases only in the last 6 months. And one of them was our patient, and another one was, from elsewhere. And for us, both the patients had had a second time CXL done. Like first time was done more than 10 years back, and they had had an enhancement done about 3 or 4 years back. So was doing what they were doing well. One of them was actually coincidentally picked up, had no complaints, just like you said, was absolutely, had absolutely no symptoms and nothing. Patient had vision of 6/9. It had not yet perforated, and when we told that young lady that you're having an impending perforation and you need to get drop in, she said, "I'll come back." And in spite of repeated calling, she hasn't come back. And she's from far away, so we've told her that in case you should see somebody locally. The other patient, I think we had managed because she had come with a perforation, and initially we did a glue, but it didn't help. Then a cornea surgeon went ahead with the surgery. So we've had only two, and frankly, it's been surprising because both of them came within days of each other and from totally different things. So exactly as you described.
Dr. Rajesh,
Yeah, I have a collection of almost 15, 16 eyes all with typical similar history. And Santosh has had, I think, 2 or 3 cases, few he has shared with us. Exactly the same clinical picture as what you have published in IGO. Your 3 cases, the clinical appearance is the same. Paras, who's here, also has about 3 or 4 cases. Nikhil has also reported something, acute melt with perforation. So these are corneas where the limbus is healthy, so there is no deficiency of the stem cells. It is just that the cornea has become like a neurotrophic cornea. So there is something to do with the neurosensory part in the area where the cross-linking has been done. You don't have keratocytes. So there is no regenerative capabilities. That's why, despite the cornea becoming thinner, you're not seeing ectasia. Paradoxically, the cornea becomes flatter and flatter. So if you have any patient post cross-linking who's showing progressive flattening and the K values are dropping below 40, going into 37, 38, that patient and has thinning as well. So that patient is likely to develop this complication in future. I think that's because there is no new collagen being laid down, and the existing collagen is gradually getting reabsorbed. So despite having the thinning, ultimately you will be left behind just with epithelium, the pre-Descemet's layer and the Descemet. That's what you see on the OCT. And it looks like a typical punched out stromal defect. So despite having the defect, and what happens is that punched out defect gets filled by hypertrophic epithelium. So sometimes this hypertrophic epithelium falls off. And then you see a very well delineated ulcer-like appearance, which some of the referred cases have been diagnosed as acute infective keratitis, and they are put on hourly medications, and they keep coming back. So this is a potential complication of, especially all of them had Dresden protocol cross-linking done, anywhere from 8 to 12 years before, and some of them have been done at tertiary care centers. So it's not like the machine was not good, or there is some fault in the hotspots or anything like that. We don't have an exact explanation, but even after doing the DALP, a lot of these patients are still, the corneas are flat, they are a little bit hyperopic, and so because the corneas are flat, we don't want to oversize, because if you oversize, you may get a mismatch between the anterior and the posterior curvature. So that's why you try to keep it the same size. But I think it does affect the overall performance of the graft, even after the new graft is performed. I think this is something that we really need to watch out for when we are doing cross-linking. Maybe the accelerated protocols may not show this complication because the total dose, means we know that the effect is more superficial. So there is some amount of the posterior cornea being still spared. And since everybody is moving away from the dextran containing riboflavin, maybe the HPMC, which swells the cornea, also may afford protection against these kind of complications.
So my next question would be, recently also we had a lot of discussion in the cornea interest group as to, is everybody still following the Dresden protocol, or has everybody switched to accelerated cross-linking? So I would like to ask the panelist again on this. Dr. Gaurav sir, can you start with us? Do you still follow the Dresden protocol or the accelerated?
No. So we moved away from the Dresden protocol almost 10 years back, and we've been following the 9 milliwatt 9 minutes protocol, which has been working well for us. We had in between for a year or so, maybe around 8-10 years back, been delving with some transepithelial like epi-on kind of treatments, and that time we had actually experimented with 18 milliwatts for 5 minutes, and frankly, out of the 70 eyes that we did epi-on, we had almost within 2 years we needed enhancement on almost 10 eyes, so we abandoned for that time the epi-on treatments, but then we've stuck to this 9 minutes, and that's working well for us, and we have had good outcomes and stable outcomes, just like we had with Dresden. So not doing Dresden, even though literature says that Dresden is still supposed to be the most superior, but compliance of patients and convenience, everything, we are getting good results with that.
Yeah, superior means here they take flattening. I mean, it goes, from 50, 60 diopters, it goes to 30 diopters. Then they say it comes as an excellent procedure. but patient-wise, it gives the worst results. When it goes to 30 or like Dr. Rajesh Fogla has mentioned, the flattening goes less than 40, you should be careful. Then it comes as a complication, but in analysis of results, it comes as an excellent procedure, uh, producing a lot of flattening. More the flattening, better the procedure. Uh, so I think at resident, we should strongly tell the people not to follow 30 minutes on the table, 30 minutes exposure. I think it's ridiculous, I feel, personally. And I think, Dr. Rajesh, you are reducing your CXL, I heard.
Yeah, I hardly do CXL nowadays. Yeah. I do very rarely, and if I do it with the accelerated protocol. But I realized that even by not doing the CXL, it has not harmed my patients in any way. So a lot of patients are coming back for follow-up, and the cornea still look quite stable. And basically treating the surface, and patients are happier. They're able to wear the contact lens better. Post CXL, somehow some of them have a haze. They feel the quality of vision is not too great. So unless I have a proper understanding of what I'm doing in the cornea, I think it's okay. I may be reducing it, doesn't mean that others have to follow. Maybe I'm just trying to understand it better, because the complications that I see, this progressive flattening and abnormal scarring, I'm not able to find a proper solution. Everybody just tells them that, okay, go wear scleral lens, but that's not the solution. So unless we need to understand, maybe we need to do something differently. So like you say that you do a cross-linking, but you don't see a haze. So, whereas everybody else uses haze as a parameter to say the success of cross-linking. So you can share what you are doing in your practice.
Good evening, sir.
The machines are all slowly, we reduce our, as I mentioned before, we don't want to see a haze. We don't want to kill all keratocytes, or we don't want to produce. I feel the haze is a complication of CXL rather than an efficacy of CSL. That's how I used to believe right from the beginning. So we reduce the energy. It didn't help us, to be very frankly, much. Then we reduce the ones we reduce the concentration of riboflavin, it helped us a lot. Once the concentration reduced from diluted 0.8%, 0.75%, then we are seeing the words. But regarding the progress, we have to wait and watch for 5 years, 7 years, what happens. But otherwise, we are able to get a sweet spot where we don't see a haze at all. Just cornea looks almost normal. Not in all cases, at least 80% of cases.
Dr. Fogla, you had
The other thing could be a different set of patient population and the overall UV exposure as well. Maybe our patient population who are in that equatorial belt, where the incidence of keratoconus is very high, maybe the response of cross-linking may be different than what you see in the European or the American population. So a lot of studies where we see good results and they don't have this complication. Like I spoke to Farhad Hafezi, showed him some of the cases that we had. He simply refused to believe. He said, no, this is something that you guys have done wrong while doing the procedure. This cannot happen with the cross-linking, which I'm pretty sure we have not done anything wrong. We have followed exactly the same protocols, and we are using many machines manufactured by them only. So it could be that maybe our patients' behavior could be slightly different, but we don't see it in each and every patient. So I think once we collate the results, there may be something else that we are missing out.
Good evening, sir. I have two things to add. Like as Vandana asked for the resident protocol, I initially started in 2013 till 15 mid. I have done the conventional method, and we started seeing that even after this first year, or even close to the second year, in very young children also, there was continuous progressive flattening. From 15 or 16 onwards, we shifted away from this thing one. And second thing, as sir rightly pointed out, sir, I have a doubt whether is it the geographical location where we are and the amount of sun rays and other things which is different on our patients is different on the other subset of patients across the world would be a cause for a different behavior towards the post C3R cases. Will it have any effect?
That's true. Yeah, in children, sometimes you have coexisting allergic eye disease, which can make the eye behave in a different way. So that's why even before you do cross-linking in children, it's very important to normalize the surface. That means treat the allergic eye disease, make the eye quiet, then only think about doing a cross-linking procedure. One of the other things when we spoke about the regional difference is that post cross-linking, if you have continued exposure to excessive UV rays, maybe that could kind of produce a continued change in the cornea, So that's why maybe if your patient has cross-linking, you could recommend that they should always wear sunglasses or UV protective glasses when they are outdoors. Maybe that may have some effect to prevent this kind of a complication in the long run. Because in the other geographical areas where they have less UV exposure, that could be the reason why they don't see the problem in that population. So I think maybe in the tropical areas, you might be the prolonged UV exposure may cause progressive changes after cross-linking. I don't have an explanation for that, but these are just various theories that we can think of.
I have a question, sir. Sorry to interrupt. Sir, yeah, after seeing all this, like I also have around 2 to 3 cases of such corneal melts after very long, like later, like after 10 years or so after Kera C3R. But I'm just thinking about if so many Downs children, they are coming with eye drops, they are presenting to us with the eye drops. So one eye, if they are presenting with eye drops, other eye, we are doing a C3R. I used to do it because like as a prophylactic thing to cause flattening and I don't want the other eye also to go for high drops because PKP is also a poor prognosis in those children. So now I'm in doubt like whether I have to do C3R in such children's. And also another query is that so nowadays also, even today I saw a patient who is around 22-year, a male who came with 60 diopter K value and his corneal thickness was around 460 somewhat. So whether such patients we have to treat it with C3R or we just leave them with contact lenses. If even like he had come to us 2 years back and his K value was around 55 or something. Now it has become more than 60. So how to go about all these patients? And
you can see again, don't misinterpret. I'm not saying that cross-linking should not be done. What I'm saying is choose the right protocol, the right energy, the right duration, explain to the patient what are the risks of complications, and then do it. Like I said, that don't use the same protocol that you're using as a standard for each and every patient. And sometimes go back to the previous records, look at it, and only if you feel that this patient really needs it or it is justified, then I would do it. I would do it in a patient, even if it is advanced, but the patient is comfortably wearing scleral contact lens and does not want to look for any surgical procedure. We can always discuss that. We can reduce the duration. There is a sub 400 micron protocol with which we will do it. But give him proper information that helps him decide whether he would like to do the procedure or not like to do the procedure. Because patients don't have that information. They just come to you and say, I have heard about C3R, I want to do it. But later on, when they develop complications and they go around different places trying to find a solution, then it is very difficult for the patient. And then they feel that they had not been provided the right information. Because if it was given to them, maybe they could have made a choice. They actually leave the choice to you, that you decide what is in the best interest for my eye. So I think that's where our judgment comes into play, that based on the current literature, information, and in your clinical practice, what you have, you should choose that and then decide what to do for a patient. Down syndrome, you mentioned, I would do a cross-linking in Down syndrome because we know that the alternate of doing a surgical procedure in a Down syndrome is very difficult. It is very difficult to do a cornea transplant because you don't have any post-operative control. So in that scenario, the cross-linking definitely scores over doing a cornea transplant, which is very difficult if it develops a eye drop. So there you can take into account, because they don't need 6x6 vision. They need vision to be able to just go around. So their cross-linking is justified. So you should not miss out. And maybe you should recommend cross-linking at an early stage.
Thank you.
So you said you keep on follow-up for quite some time. So do you keep them on like vitamin D supplements and cyclosporin topical, or do you follow any of the regimens? Anything in specific?
In terms of topical lubricants and topical cyclosporin are given in patients who have had an active surface. Otherwise, or somebody who has an active eye rubber and has some component which tells you that. So there you, maybe if it is active, then you try to treat with low dose steroids and lubricants, get the eye to become very quiet. And then to maintain that, maybe you can use some topical cyclosporin over a long period of time. That has also helped. I've seen patients who come back and say, oh, now I stopped eye rubbing. And then when you do your test, you find that they look quite stable. So documenting progression is, keratoconus is not that rapidly progressive in adults. So, it doesn't go haywire in few months' time. So it's always better, you can always educate your patient and then decide whether to do the treatment or. Gaurav, you were asking something or any comments?
Yeah, I was just trying to say that, if we look at the percentage of patients who end up with sight-threatening complications, at least in my practice, I've been doing cross-linking for maybe 15, 16 years. We started way back in 2005 and should have
Right.
at least about 1,500 eyes through documented nicely with annual follow-ups and, serial pentacams and everything. And as
True.
everybody has said, that flattening used to happen much more with the Dresden protocol in my first 5 years of practice. And then we've seen, lesser of that progressive flattening. I mean, we see flattening over a year or 2 or 3, and then we see good stability. So I'm just thinking that, if I'm not the kind, I'm very, very fussy about, not cross-linking patients on the first go. I mean, I would keep them on follow-up, counsel them about eye rubbing, sleeping posture and everything, treating the ocular surface allergies and documenting progression or fall in vision. And then if necessary, I would cross-link. So I would probably end up, treating only maybe less than 20 to 30% of my keratoconus patients who actually have progression, which is documented or visual, kind of symptoms. But I would not hesitate to cross-link them, seeing the cost-benefit ratio that, the number of patients who benefited from cross-linking by stabilizing and, their vision, we being able to save their vision from deteriorating, the quality of vision from going down. So again, I would not want to be an alarmist either about, the risks and complication of CXL. It has shown more than 90% of our patients, or maybe even 95% patients benefiting. But yes, I mean, indiscriminate cross-linkings, treating patients on the first go, I see so many patients who've been done one pentacam done for the first time, diagnosis keratoconus, straight away advised cross-linking. And then, it's like scary to see that. So I think the message has to be on both sides. Like, we have to be careful on both sides.
Right, Gaurav. You're perfectly right. And I completely agree with you. I'm not, see, my practice is more of a referral practice. So I see more of the complications that come to me. So the volume of complications I see are more. I don't see some of those primary keratoconus patients, but then you have a huge number of general ophthalmologists who do cross-linking. And as you mentioned clearly, some of them do the moment the patient is diagnosed with keratoconus on topography, whether it is early stage or mid or advanced, they undergo cross-linking procedures straight away. Sometimes some have done both eyes on the same day. So I'm not. So what we are not trying to send out a message that it should be completely should not be done. What you pointed out, that document and do your cases selectively. Definitely, there is a role for cross-linking. There is that is not debatable. We a lot of studies, even RCTs that have been done on cross-linking, have shown the beneficial effect in the amount of stopping the progression and causing flattening as well.
So we have another question from the chat box. Actually, the role of vitamin D3 supplementation in these keratoconus patients. Dr. Gaurav, can you tell us about your experience? Do you give vitamin D3 supplementation to all your patients, or is it a routine?
No, it's not the routine. We were not giving it so far, and now we've been kind of debating whether we should. But what we've started doing is that we are now monitoring vitamin D levels, and also over the last few years we became aware of the role of thyroid disorders, and we've been starting to check our patients for that as well. But in a select group of patients where we saw haze and where we wanting to kind of treat them better, we have done supplementation because when there was little else to do. But frankly, we don't have a clear kind of picture of whether we should be doing or not. And I would love to hear from all the other colleagues on this as well, because it's a small gray area for us.
Dr. J.K. Reddy, your opinion on vitamin D? Because I know that we supplement all our patients with vitamin D3. So can you please unmute yourself first? So can you unmute?
You're muted.
Yeah, exactly. So we don't know the role of exactly vitamin D3 in this. There's no specific anywhere in the literature or anything. But most of the people around the world are deficit and it's supplementing. So it is just a routine supplementation. D3 and B12 are the new fancy things in now going on health sector. Even obstetrician never used to give D3. Now, almost for the past 3 years, every girl with a pregnancy is supplemented. So we are also doing like that. That's all. Routinely, I supplement all my patients with the D3 and lubricants.
So
In the interest
my
of time, can we move to the
Next session.
yeah, I was just
next
going to say
session?
that.
Yeah.
So can we please move on to the other two presentations? Shabina, can you please have the presentation?
Good evening. We will be discussing a case of a 24-year-old female who was recently diagnosed with keratoconus and was referred to us for further management. She gave history of recurrent allergic conjunctivitis in the past. There was no other significant medical or family history. On presentation, her best spectacle corrected visual acuity was 6/12 in the right eye, which improved to 6/6 with RGP lenses, and scissoring was seen on retinoscopy, whereas the best spectacle corrected visual acuity in the left eye was 6x parts. Tomography confirmed central cone with maximum keratometry of 51.1 diopter in the right eye with thinnest pachymetry of 448 microns. Maximum keratometry was 46 diopters with thinnest pachymetry of 468 microns in the left eye. She was advised corneal collagen cross-linking in the right eye followed by left eye for keratoconus. Cross-linking was done as per the Dresden protocol, where after epithelial debridement, riboflavin was first instilled every 3 minutes for 30 minutes, followed by UV light irradiance. The eye was patched, and subsequently on the first post-operative day as well, the eye was patched again in view of the epithelial defect. On the second post-operative day, along with the epithelial defect, mild diffuse cellularity was seen. A bandage contact lens was placed and topical moxifloxacin was started along with loteprednol 4 times per day. On the next day, the cellularity increased along the superior edge of the epithelial defect. Literature review suggests that both sterile infiltrates and infectious keratitis can be seen after conventional cross-linking. Infectious keratitis can occur due to the time taken for complete reepithelialization. Although the overall frequency of infection is low, due to the use of topical steroids post-operatively, the keratitis may progress with moderate to poor visual outcomes, with some ultimately requiring keratoplasty. So we went ahead and did a corneal scraping to rule out infective foci. As no organism was seen on microscopy, oral steroids were started with clinical suspicion of an immune-mediated response. On the fourth day, as the defect reduced in size, the same treatment was continued. Topical dexamethasone was started in tapering doses along with tapering oral steroids. Over 2 months, the infiltrates resolved gradually. We went back to the literature to search for the possible risk factors which could have led to sterile infiltrates in our patient. As per the literature, sterile infiltrates are a rare complication after CXL. Although the exact etiology and pathogenesis has not been established, the possible risk factors include blepharitis, post-operative use of topical NSAIDs, thinner and steeper corneas, and history of VKC. We ruled these out in our patient. She did not develop any allergic exacerbations. Systemic evaluation was done, which was normal. External ocular examination was done specifically for the lids to rule out blepharitis, which was also normal. Left eye CXL was done after 1 year, but she developed a similar post-operative course in the left eye as well. Sterile infiltrates developed on the second post-operative day. This time, oral and topical steroids were started early and the sterile infiltrates resolved within 1 month. My question to the panel is, what could have been the reason for this bilateral sterile immune reaction in this patient, and are there any predisposing risk factors? Thank you.
Can we have the next presentation as well, Dr. Sri Lakshmi's presentation?
Yeah.
Yeah. Dr. Vinay, please go ahead. Can you play the next presentation? I think there seems to be a small delay in playing the next presentation. So I think we'll go ahead with the questions. My first question would, to the panelists would be, what is your post C3R protocol? Do you place BCL for all patients, or do you start steroids on the get-go, or do you just patch and keep them on antibiotics? Dr. Gaurav, can you please take this question? So can you please unmute yourself?
Can you please repeat that? Because for some reason there was a network issue in between and I just got disconnected for a few seconds. Yeah.
Not a problem. I just wanted to know your post C3R protocol. Do you place bandage contact lens for all patients? And what is your protocol? How long do you give steroids for? Protocol that you've been following these past years.
Sure. So we do put BCL on all patients, and we start them on topical moxifloxacin and topical steroid. We typically give chloromethylone and a lubricant, and we give vitamin C to these patients. We are still not doing vitamin D3 as you were suggesting. Our topical steroid protocol is for 2 weeks, and if necessary, it can be extended up to 3 to 4 weeks. But most often, these patients will receive topical steroid for 2 weeks, topical antibiotic for 2 weeks, and lubricants for a month. And then, of course, after that, if required, they can be continued on lubricants. And we, of course, these patients also receive oral this thing on the first day, anti-inflammatory, and then after that, they are not kept on that. The bandage contact lens is usually removed on the 3rd to the 5th day. That's our protocol. Yeah.
The steroids and antibiotics are started on the same, on POD1, you mean?
Yes, yes.
So I think our next presentation is ready. So Vinay, if you can go ahead and play the presentation.
I'm presenting a case that we encountered in our OPD, a post-cross-linking infective keratitis. 13-year-old male patient who had complaints of blurring of vision was diagnosed with keratoconus in both eyes. Patient underwent right eye C3R first, followed by the other eye C3R in a span of 2 weeks interval. He had an uneventful surgery. On post-surgery, a bandage contact lens was placed in the eye. He had a slit lamp examination also before discharge, and discharge was done on the same day. As a routine, we keep the bandage contact lens for 5 days. Once the epithelium heals, 5 days post-op, patient will come to OPD and we will remove the contact lens, and then we will start steroids on day 5. Same routine was followed in this patient also. Patient was given Vigamox and Lubrex eye drops to be used 6 times a day. Along with routine post-op instruction, patient was discharged. 3 days post-cross-linking, patient came to a night emergency OPD with severe pain and redness in his left eye. Vision was hand movements. On examination, there was copious discharge, circumcorneal congestion, corneal ring ulcer with well-defined margins, full thickness infiltrate in the cornea with endoexudates was noted. There was 1 mm hypopyon also seen. As the patient presented in the night OPD, we couldn't send the contact lens for culture. Contact lens was immediately removed, and empirically patient was started on hourly Vigamox eye drops along with the cycloplegics. Next day morning, when the patient came to OPD, we did the corneal scraping and the grams was positive for gram-positive cocci. 3 days post the scraping, we got the sensitivity and culture report. It was methylene sensitive Staphylococcus aureus, and it was sensitive to moxifloxacin, which the patient was already using. Along with that, there was it was sensitive for vancomycin, gentamicin, amikacin. Patient was started on vancomycin on day 3 based on the culture report along with Vigamox. Patient was coming daily for review visits, and day 3 itself we noticed a reduction in the endoexudates along with a reduction in the hypopyon size. Day 5 there was total disappearance of hypopyon, and endoexudates also disappeared. There was early blunting of ulcer margin noted, which indicated which gave us a relief that the patient had a clinical improvement and it was signs of healings were there. Day 15 there was early scarring noted, and along with that there was diffuse erosion in the cornea suggesting of surface toxicity by the vancomycin. So vancomycin was tapered to 4 times a day along with Vigamox 6 times a day, and topical steroids were also started at this point. Day 30 there was total scarring of the lesion. Antibiotics was stopped. Antibiotics was stopped, and steroids were tapered at this point of time. Best corrected vision acuity was 6/36 and N10. On subsequent visits, around 3 months post the healing, patient had a scleral contact lens trial and vision was improving to 612 and N6 with scleral contact lens. This patient reminded us the importance of not taking C3R patients very lightly, though it is the most common and the easiest surface procedure that a cornea surgeon would do. Utmost care should be given to prevent any post-op infections. Thank you.
I'd like to request Dr. Sri Lakshmi as well as Neha Jain to unmute themselves. My question would be to the panelists, Dr. Prabhu J. Raghavan. Sir, your comments on the infectious keratitis post C3R case. So I know that you've been in a large volume center all these years. So can you just tell us a bit more about your experience?
Yeah, I think whenever we are doing any procedure where we are debriding the epithelium, we really have to be the first thing which we have to always have in mind is a possibility of an infection. Fortunately, then I had seen one case of my own long years back in 2015 or 16. I do remember that time we used to admit the patient for 2-3 days. We never started the steroid. I have never started a steroid along in the first day when the epithelial defect is still on. And I've used BCL for all the cases. And usually I start my steroids only after the complete closure of the epithelium and removal of the BCL. Fortunately for that, the first day or the second day, there was a delay in healing of the epithelium, and I had noticed a small infiltrate starting up. Scraped it. The cultures didn't grow anything, and but it showed some gram-positive organisms and started on antibiotics in full swing and got escaped out of that case one. And this was my own case. And second case was a case which was referred from a neighboring state. Of almost in the second eye of the C3R, first eye left eye was done, and the second right eye after 1 month or so, young female, and patient had a typical history of a BCL slip, and the way in the OPD the BCL was replaced, and it developed an acanthamoeba ring keratitis ring ulcer, very bad. It went very bad, and we had to go for a penetrating keratoplasty. I had presented this case in ASCRS as well as we have published it also. So it was a proven case of acanthamoeba keratitis. So these are the two cases which I have personally have a infective infection post C3R. But sterile infiltrates, yes, definitely I have seen few cases, but whenever we see a sterile infiltrate, most of the time we can see that it's not, the patients are not so symptomatic. Once at the look of the cornea, we are almost like shocked, but the patient is still not very painful. They are just maintaining as normal patients. And we could clinically, we could definitely differentiate between the two, but still it is when it is so not healing, it is always better to rule out microbiologically and be judicious in using the steroids initially to see the response, and then if it is, yes, if it's not worsening, then hike the steroids. These are the two cases and few cases of sterile infiltrates which I have seen, Dr. Vandana.
So actually, CXL is used for treating infections. So back CXL is used for treating infection also. And here
Yeah.
we are talking about CXL and then which has caused infection. So probably it is the external factor which has caused infection. Sterile infection is very common actually. It's not that rare. Reddy sir, would you like to comment about the active infection? Sometimes patients are treated during active allergy. I'm sorry, and they usually end up with sterile infiltrates.
Yeah, that's as Dr. Rajesh has rightly pointed out. Ocular surface treatment is very important before you take up patients for CXL in keratoconus associated with ocular surface allergy or whatever inflammation, whatever you see. Restoring the ocular surface is very important. The sterile infiltrate, I am very hesitant to use the word sterile. I feel it's an immune infiltrate. Just like you see in marginal keratitis, it is not a sterile infiltrate, marginal keratitis, what you see. It is immune mediated between the staphylococcus antigen and antibody, right at the right combination. And the patient should have antibodies in their body. Otherwise, you don't get an infiltrate. Even a little bit staphylococcus growth can produce, which we cannot see, or it cannot produce any manifestation. Maybe there is a small sterile infiltrate. Most of this immune infiltrate, I feel there may be very low grade infection, but it produces a typical what they have shown first presentation. The moment you see it clinically, we can say it's immune infiltrate, multiple infiltrates all around circular fashion, not in the center, in the periphery, mostly subepithelially, below the epithelium. So those cases we give both steroids and antibiotics, they do very well. But the central ones, if it's anywhere in the center 4 5 millimeters, if it comes, they are not immune mediated. Mostly they are infective. So naturally, it's at half-an-hour procedure, leave the patient, go home, and that can produce. There's a high chances. Actually, I feel CXL has the highest, whatever I look at into the literature, the complications of CXL are more than complications of cataract surgery, but CXL is performed less infinity than cataract surgery. The number of surgeries you take cataract surgeries, they're so large, and the complication, infective complication is very, very low. If you take the same number of CXL, the number one infective surgery in ophthalmology is intravitreal injections. Number two is CXL. So this is not CXL is not very rare. In ophthalmic surgeries, surgeries, number one is number two. In vitrea and cornea, we are competing.
So I think due to short of time, we'll move on to the next presentation. So the next one is not basically, it's not cross-linking per se the case, but it's something quite interesting that we've noticed for the past few years. So Mr. Vinay, can you please play the PPT?
Good evening, everyone. I'm Dr. Ankita Thali, and I'm here to present inverse keratoconus, myth or mystery. This is a case of a 19-year-old male with both eyes keratoconus. Left eye had advanced keratoconus, as can be seen in the pentacam images. His best corrected visual acuity in his right eye was 6/9, while that in the left eye was 2/60, not improving with pinhole or glasses. He underwent corneal collagen cross-linking in his right eye and a deep anterior lamellar keratoplasty in his left eye. A big bubble dark with a graft size of 8.5 mm was performed. On the left side is a preoperative image of the left eye showing advanced keratoconus, while on the right side is a postoperative day 10 image showing a clear dark graft with intact sutures. All sutures were removed by 1.5 years and the best corrected visual acuity was 6/12. However, at 3 years follow-up, there was a drop in vision noted with the onset of central anterior stromal haze, as can be seen in the clinical image. An ASOCT was performed which also showed central anterior stromal scarring. The best corrected visual acuity was now found to be 624 parts. Pentacam was then done which showed central flattening, and serial pentacams at 3.5 years and 4 years showed the same. These are two other patients with similar histories, clinical photographs showing central anterior stromal scarring and pentacam showing central flattening. Keratocytes are mesenchymal derived cells of the corneal stroma. They are normally quiescent but can readily respond and transition into repair phenotypes following injury. This repair can either be regenerative or fibrotic, and this depends on the exposure to various epithelial derived factors. In keratoconus, the behavior of the keratocytes is abnormal, with higher rates of cell death and loss of extracellular matrix. This is attributed to an imbalance in the signaling at the molecular level from the epithelial cells, which is exacerbated by environmental factors or complications such as ruptures in the Descemet's membrane and the Bowman's layer. In post-Dark cases, the keratocyte density is significantly reduced and their arrangement is profoundly altered. This could be due to the mechanical trauma to the tissue during the surgery, transient dysfunction of the endothelial cells, and the presence of debris at the interface. I would like to conclude by saying inverse keratoconus is definitely not a myth, it is a mystery. Histopathology of the graft can probably throw light into this entity. These patients are rehabilitated with rigid gas permeable contact lenses. Thank you.
Yeah, so my question would be to Dr. Popla. Sir, have you come across something like this? Patients post-talc are presenting many years later with central flattening. So we,
Yeah,
yeah.
I do have such cases, and I've had to do a repeat DALC to manage the problem because of that central flattening, which results in hyperopic shift of 5 to 6 diopters. Patients are unable, and the haze also, so they don't get really good quality of vision. I don't have an exact explanation for that. So one of the reasons I could think of that, because usually for DALC, we sometimes take very old donors, because the eye bank provides you and says, okay, for rest of the cases, you use younger donors. But for DALC, if they say they give you 80, 85. So I feel that it could be that the quality of donor tissue that you have used itself, we know that as you grow older, the tissue gets more cross-linked. So the collagen behavior is different. And the second thing is that all these keratoconus patients, the tear film may contain certain other cytokines compared to, because we don't see such changes after a PKP, because in PKP also we have the same graft-versus junction, the same amount of neurotrophy because you have cut the nerves. So similar changes should have occurred in PKP also, but if you don't see it PKP, you see it in DALC. I don't have an exact explanation. Sometimes using the same size donor also, because progressively as the graft-versus junction heals, maybe that has an effect on flattening the central cornea, much more than what you do in PKP, where the posterior border is also excised. So maybe the tissue distribution forces are different. But we don't see routinely. I've had patients, both eyes that I've done DAL. One eye shows cornea is perfectly fine, but the fellow eye shows this central haze. And it's like what you see in the similar cases of cross-linking, where you see that flattening, the haze in the center flattening. Here also, we are seeing exactly a similar picture. So it's like no cross-linking done, but the clinical appearance of the haze and the flattening is quite similar to like what you see. So it has something to do with the collagen turnover being affected and the collagen not being laid down. And that results in that kind of a haze and typical picture and the flattening.
Dr. Reddy, your take on this?
Yes, just a puzzle. I asked them initially, most of the surgeons, we never see in our patients. So I got confused. Why I alone on the earth I am getting? Now I got Rajesh also supporting me. He is also get somebody. So I have company now.
No, I've done a repeat DALC. I would see maybe about 6 or 7 eyes where we have done the DALC, and we have sent them for routine histopath. But in routine histopath, they are not able to pick up much changes. So I think if you want to really see, you'll have to go in for maybe an electron microscopy, or you need to see somebody look at it at a much higher magnification to look at the keratocytes and see how. My theory is that in the area of flattening, you will find a zone of absolute loss of keratocytes. Maybe next time, and we are not allowed to send tissues outside India, so I'm not even able to send it to somebody in the US to process the specimen and give me the findings.
So this was something interesting that we had come across, and that's why we just wanted to have
the other finding also you will see in DALC is that sometimes we see the peripheral cornea. Initially, when you put your graft in and you suture it, you, with the help of sutures, by taking a 70-80% bite on the donor side and a deeper bite on the host side, you're able to get the anterior surface become very flush with the host edge. But over a period of time, when you remove the sutures, you will see a slight step-like deformity. That means you will find that the graft-versus junction, the donor looks a little steeper. So if you do a topography, you will see a nice circular red patch just at the graft-versus junction. The peripheral part, because it's slightly flatter, so that also has a refractive impact. So patients, sometimes the quality of vision is not too great. So I think that's why Massimo Busin, when he does his DAL, he doesn't use a full thickness cornea in all his cases. He just uses a 400 or 450 micron graft. And he says that he gets a much better graft-versus junction apposition instead of using a full thickness cornea.
Here's that's okay. The suturing, the flattening, all we can explain by so many things. The surgical technique may be wrong or maybe different, but the haze is the one which is not there in the before. Exactly as you are telling, it just looks like a CXL haze, subepithelial haze, and progresses with the time. That's
I have tried treating them with steroids and other things when I see them very early on, and I have a feeling this is going to, but nothing has helped. No amount of steroids, lubricants. So no medical therapy has made it, slow down or reverse It's a progressive thing. In few of them, we have even done a hyperopic laser ablation to kind of manage the refractive error early, but that is a short-term effect. You do the laser, the effect is there for some time, but a year or two later, they are again back to the same further hyperopic shift. So finally, changing the graft has only solved the problem for me in these eyes. So now I have stopped taking very old tissues for DALK. I tell them I will not take anything above the age of 80, 85 for my DALK, because sometimes iBank will tell you, I have a 90-year-old donor. Previously, I would just take it. I said, okay, DALK, it doesn't matter. But now I think I still feel that maybe you can. So sometimes combining, I do a DMEX, so I have the donor, so I use that for my DALK. So that way we can use it. But these are again things I think we don't have. These are all hypotheses that we make, but we need to really study them better and get an ultrastructural imaging. Even confocal would help. I don't have access to a confocal, but if somebody has these kind of cases, do a confocal and see an in vivo imaging. You may be able to identify better. You may be able to see the keratocyte density in the periphery and in the area where the haze is. And that's worth investigating. Even look at the corneal nerves. You can do that on confocal. You can, and if even the corneal nerve density is reduced in that area, so that kind of gives us some explanation as to why we are seeing this kind of haze and flattening post-DALK in the center.
So I think we've had a great discussion on all different types of case presentations, and we've almost come to the end of the session. So we've had a very a wonderful session, and a big thank you to all our panelists. And over to Dr. Nyanmedi.
Yeah, thank you very much. Thank you all the panelists. Just before we go, I have a question. In one of the case presentations, we had a sterile or rather immune infiltrate in the second eye also. How common is that? And then what should we do just to prevent that in the next eye when we do a CXL in the next eye, the second eye?
Did they use a contact lens in the second eye as well? Was a bandage used in the second eye as well?
Good evening, this is Neha. So actually, normally after cross-linking, we do a patching, and only after the epithelial defect is healed, we do start the topical steroids. But because in the first eye, the epithelial defect was there along with the immune infiltrates, that's why we had placed a BCL and then started the topical steroids. So in the other eye also, because on the second day after we opened the patch, the infiltrates were there, that's why we placed the BCL. Otherwise, routinely we don't place the BCL after doing cross-linking.
So at least in my practice, ever since I started cross-linking, I've never put a BCL in any of my cases. I always patch. And the reasoning being that next day morning, I want to see how the epithelium healing, because some of these cases where you do cross-linking, especially in children who have had allergic eye disease, they can have something like a partial limbal stem cell deficiency because of the limbal papillae and this kind of, so they can have delayed epithelial healing as well. So to manage that, and next day, if I don't put a BCL, I can examine the cornea much better, and if required, I can put a drop of fluorescein also to see what is the size of the defect. And in case if I feel that there is the epithelial healing is not good, normally by next day itself, almost 30% of the epithelium is healed in a healthy eye. So then I can take preventive measures to try and see how I can, or the follow-up visit I can schedule. And most of the papers in literature where you see infections or infiltrates reported after cross-linking, when I looked at it, I found that almost every paper had one common factor. All the patients had a bandage contact lens after cross-linking. So then somebody asked me, sir, what do you do after PRK? I said, yes, after PRK, I put a bandage contact lens in all my patients. Then they said, it's the same logic you apply. You have an epithelial defect. Here you are putting bandage contact lens, so why not in post-cross-linking? But in post-cross-linking, you have to understand that you're exposing the eye for a much longer duration of time compared to a PRK, which lasts only less than few minutes, where you are doing the laser and you're immediately putting a bandage contact lens. Here, you're debriding, you're putting drops for 30 minutes, then you're exposing the eye to UV light. So, and at the same time, the UV radiation kind of blunts the healing response. It's not no longer a normal eye. So the defense mechanism is compromised. So there, if you put a bandage contact lens, and because your eye has been exposed for such a long period of time, the risk of catching an infection and the eye not being able to, work against it, it can be difficult. Most of the gram-positive cocci infections, again, after cross-linking, have all ended up in therapeutic keratoplasty. You have to understand that the gram-positive cocci usually are multi-drug resistant, and often they don't respond. So to prevent that, I think if you put a patch and see the patient the next day, and next day if the patient looks fine, but the patient is very symptomatic, and then if you decide to put a bandage contact lens, that's still okay because you have seen the healing response, and then you have decided to put a bandage contact lens. But next day, if my patient did not have a healing response and the eye is looking, I would still continue patching till I see the healing progressing, rather than just going ahead and putting a bandage contact lens on that eye.
Thank you, sir. Yeah, we had
Rajesh,
a
can I
very
chip in with
yeah,
something? I'm sorry.
yeah, sure.
Go
I
ahead.
No,
was
go ahead.
tempted to chip in. So what we are doing is we are using bandage contact lens right from day one, which means like 2005 or 6. And I've been using it. And see, initially we didn't have the advantage of having epithelium mapping on OCT, but now for the last 7-8 years or maybe longer, we do monitor epithelium healing response. It's very nicely visible under the contact lens, and you can see how the epithelium is healing. Our patients do well. That's because I started doing PRK in something like 2002. So maybe that came naturally to me putting BCL, for my CXL patients, and that was the protocol described when we were visited by this guy from Theo Seiler's group, Dr. Hans-Peter Rizeli, who had come to do the first surgeries in one of our live surgery workshops. So we started like that, and since we kind of did well with that, we've kept on with it. So we do monitor epithelium healing responses. We don't have situations with that. We do start topical steroids on day one itself. And we monitor. Usually it's by the 3rd or 4th day we notice that the epithelium healing is good, and once we notice that it's kind of filled in, we would remove the contact lens on the 3rd or 4th day. Patients are much more comfortable, that I can understand. And we notice that whirl-like closure, as you see post PRK also happening with CXL as well. There'll only be an occasional patient whose healing response may be slower than our usual patients. Maybe carry on for a BCL for up to a week. In fact, the only area where we did have delayed healing, funnily, was as I said, was the epi-on patients, where for the first 3-4 days, their epithelium used to be great. And then, they would suddenly break down. And then, you would have these epithelium breakdowns lasting, sometimes almost a week or 10 days after that, I was putting them on a BCL, funnily enough. And so that's why over a period of time, we abandoned doing that, because epithelium sometimes used to break down even after a week, which was very, very peculiar. So frankly, I am quite happy putting a BCL. I'm happy to monitoring these patients on epithelium mapping on OCT and looking at their progression of, how they are responding and the epithelium is healing. And we've been comfortable. Eyes look much quieter. And frankly, touch wood, I mean, maybe, I'm talking just, it's more like I don't have a documented or published data, but, monitoring almost 1,000, 1,500 patients, we don't get to see, and I don't want to start seeing them. So I'll just stay quiet about it. But we don't see these infiltrates so often. We've had only 1 or 2 infectious infiltrates. One was on a patient with a scleral contact lens who was, using it for long periods, used to have irritation, and suddenly came back from Delhi, where she had been seen there by another doctor, and we managed that sterile. But that was a infectious keratitis almost like 6 months after the cross linking. But touch wood, we are doing okay.
Yeah, I think still a majority of people doing cross-linking, you do use bandage contact lens, and the ones who patch may be a very small minority. But I just giving a logic, whether you put a bandage, it's not like bandage contact lens is contraindicated, but keep a close watch. Don't put a bandage contact lens and send the patient away and call the patient after a week, and then see the patient, because if you are not very careful and the patient does develop an infection, it can have disastrous consequences. So at least till the epithelium heals, please review the patient the next day and see maybe on the 3rd day again, and make sure that the cornea is healing well. And don't do simultaneous bilateral cross-linking and put bandage contact lens in both eye. Treat judiciously. And like for me, I'm comfortable patching. My patients are comfortable in terms of the pain score. I don't think they get a better pain relief by putting a contact lens. But it's my individual practice. And that's how, even when we started doing PRK back in 97 at SN, we were doing only 1 eye at a time. And we always used to patch our PRK patients as well. And so maybe this thing comes from that. And later on, refractive surgery, we all moved on to using bandage contact lens. But since it's working well in my practice, I've never changed. I've never moved away from it to use contact lens. But definitely, it's like Gaurav pointed out, there is nothing wrong in using a bandage contact lens. But be careful. Bandage contact lens solutions also have contamination. Recently, there was somebody who sent me a report. They were getting infection after using the bandage contact lens in all their cases, post-corneal surgery, post-refractive surgery. And they sent that batch of contact lenses to the micro and found the solution had Pseudomonas in it. So that again, something like you just have to be careful. Don't use off-the-mill contact lenses. Use standard contact lenses from a reputed brand. and no cost cutting in any procedure that you do. Bandage contact lens don't cost a huge amount.
Thank you, Dr. Fogler. Before we wind up, Dr. Himanshu, I think he has something to say. Yeah.
No, just one point. Amazing session, and I think just about the contact lens part, Gaurav said that he uses, and I too have been using contact lens and steroids since last 15, 17 years. But one important thing which we have to remember, these are keratoconic eyes. So many of them, they don't have good fitting of contact lens. So be aware that if somebody, you put a contact lens, if contact lens is very tight, a tight contact lens is a disaster in waiting. So just be aware that when you put the contact lens is not tight and you're not getting a tight lens syndrome kind of thing, or stuck lens kind of thing, that itself can lead to significant morbidity. So just a point to convey there.
Thank you. I think we had a very great session today. There are so many things to discuss and then continue the discussion also. But we are short of time. We'll end up here until the next Kera Grand Round. See you there. With this, we'll end this session. We'll thank all the panelists, the speakers, and the participants once again. Good night.
Thank you, Gyan, for putting together this Grand Rounds.
Yeah, thank you, sir.
Thank you.
Paras is smiling. She's very happy. Okay.
Congratulations, Gyan.
Thank you, ma'am. Thank you.
Yeah.
Great job. Very nice.
Okay. Good night. Bye.
Good night, sir. Good night.